Sir, are my slides visible?
Yes, sir.
Yes, Prabhu.
Okay, so shall I start?
Yes, I guess. Yeah.
Okay, so welcome one and all. It's a great pleasure on behalf of mankind to welcome all of you to a very unique series that you might have heard in all the teasers, One Key That Fits All. And it's a series which will take place chapter wise. So it will be a series which will talk about the impact of anxiety and depression in related disorders of the entire body. And the chapter one, very interesting that we have taken a first is brain and gut a concomitant relationship. So before going on to the series, Mankind Pharma marks 25 years of its existence in 1995, and we are all indebted to the support that all of our premium customers have given us to achieve this feat and our endeavor to serve humanity like we have done as always. So, from directly from our chairman, Mr. R.C. Juneja, our vision is to become the most admired Indian pharma company. And in the time when the industry needed us the most, mankind truly stood by what its name meant that serving lives, we live up to our values and our name, mankind. So, when it comes to donations to common people, to taking care of the medical professional and the supporting staff, and even the policemen, various we took various initiatives in the welfare of our co-colleagues. So there are few initiatives that we took, that all of the mankindians donated one day's salary to the PM cares fund, and we and also we pay respect to all the support staff, doctors and the policemen by pledging 100 crore contribution to those who made this supreme sacrifice for the nation in these unprecedented times. Also, I would like to bring to your notice that Mankind Pharma proudly announces the global patent of a first-in-class novel anti-diabetic molecule GPR119, for which we have a patent till 2037. Now, I would like to hand over the session to Dr. Prashant, who is a senior manager from Mankind Medico Marketing team, who will take on from here and will introduce you to all our speakers. So, sir, over to you.
Thank you, Pramjot. Before I introduce our speakers, I welcome everyone once again to this unique session. And why this is unique? Because we are already aware. I mean, during this pandemic, this anxiety, depression. I mean, these are something few neglected topics. I would say we have, and how these anxiety, depression are also linked with our alimentary system, our gastrointestinal system. So to speak more about on these topics, we have very distinguished speaker with us. First, let me introduce you to Dr. VG Mohan Prasad. He is having more than 34 years of experience in the field of gastroenterology. He is inventor of Homoseal spray, which is an endoscopic device to control gastrointestinal bleed. He has established a center of excellence in India to train doctors on therapeutic endoscopy, which is accredited by Indian Society of Gastroenterology. Till date, he has successfully completed more than 50 programs benefiting more than 500 specialists from India and abroad. He is also the adjunct professor of the Tamil Nadu Dr. MGR Medical University. He has been national past president of Indian Society of Gastroenterology, national past president of Society of Gastrointestinal Endoscopists of India. He is also advisory member for the National Board of Examinations and teacher for DNB Medicine and Gastroenterology for the past decade. He runs a course on fellowship in therapeutic endoscopy under the Tamil Nadu Dr. MGR Medical University for the past 6 years. Welcome, sir. Now, let me introduce you to our next distinguished speaker, Dr. Rajesh Nagpal. Dr. Rajesh Nagpal is consultant at Manobal Clinic and is situated at Rajouri Garden, New Delhi. He is also partner at Sarvam, which is a neuropsychiatric center at Jaipur and Kalkam. He is also trustee at Deva Foundation, which is Anvita, which is Asia's largest women rehabilitation center. He is also chairman section on developing nations World Psychiatric Association. Also director of Behavior and Neuroscience Academy of India and director and professor at Institute of International Organizational Psychological Medicine. Dr. Nagpal is also a steering committee member of North Indian Bioethics Unit of the Asia Pacific and Bioethics Network of the UNESCO Chair. He's also Associate Secretary General in Indian Global Psychiatric Initiative, past President, Indian Association of Private Psychiatry, past President, Indian Association of Biological Psychiatry, and past President, Society for Bipolar Disorder. Welcome, sir. Now, with this, uh, as we are aware, first we would like to hear from Dr. Rajesh Nagpal, sir, about the role of brain. Sir, over to you.
Thank you, Dr. Prashant. Thank you, Dr. Mohan. Thank you for all the lovely words for actually both of us, and thank you and the entire audience who is going to listen to us, and thank you to Mankind Pharma for holding such a topic. I will our introduction into the second brain or the gut brain microbiome is about 6 to 7 years old. We have been uh, holding a series of talks internationally and nationally. It seems to be very interesting for most of us who are working in the field. Uh, so, in brief, this I'll go very fast and very brief because Dr. Mohan will get the major chunk of the presentation. But this is a cartoon of the gut-brain microbiota axis. So basically, there is in the brain, as we know, the hypothalamus, the CRF, and the entire HPA axis, which influences the gut and the cortisol, and then it affects the immune system, affects the enteric muscles, the tryptophan metabolism, and through the vagus nerve also has a direct effect on the mood, cognition, emotion. So this cartoon tells you in brief about this whole issue of a second brain. We know that the gut has a huge diversity, and Dr. V. Mohan will talk about it in great detail. I won't spend much time, but our guts are hugely diverse. And of course, we have an ambitious project even in the Indian context, which came up about 2 years ago. The New York Times talked about it, that provocative data strongly suggests that intestinal microbiota could be harnessed to fight disease, and this prospect has garnered significant attention. And today, in new companies offer personal analysis of fecal microbial content, promising consumers inroads into personalized health, while untested and potentially risky do-it-yourself instructions for microbiome cleansing are proliferating online. We are all aware of that. The caveat is that it is uncertain as of now whether one can generalize from controlled animal studies to the more multifaceted pattern of human pathophysiology, especially with regard to the therapeutic potential for neuropsychiatric health. There has been a paradigm shift which I like to focus upon. It's from gut dysbiosis to altered brain function and mental illness mechanisms. The disruption of the microbes that are resident of our GI tract has long been implicated in the development or exacerbation of mental disorders. The microbiota is shown to regulate many key processes in adult brain, such as the neurogenesis and microglia activation. Thus, the ability to target the brain via the microbiome is viewed as a paradigm shift in the neurosciences, in the neuroscience and psychiatry. So that is where we are now heading with the probiotics, etc. So, impact of the GI tract on brain function has long been recognized through pioneering work of Claude Bernard, Ivan Pavlov, etc. Walter Cannon, the founding father of the study of gastrointestinal motility, emphasized the primacy of brain processing in the modulation of gut function, and even Charles Darwin recognized the importance of the interaction in his classic, The Expression of the Emotions in Animals and Man. Very long standing history. There has been long history of anecdotal reports of psychiatric side effects of antibiotics, even in those without a pre-morbid psychiatric history, and we are all aware of that, being clinicians, the audience primarily clinicians. In the first decade of the 20th century, probiotic preparations containing lactobacillus strains were marketed widely as a means to improve mental health and treat psychiatric disorder. But there are some startling facts which I like to bring to your notice. The human gut harbors a dynamic and complex microbial ecosystem consisting of approximately 1 kg of bacteria in the average adult, approximately weight of the human brain. It has been postulated that in the absence of bacteria, humans would not have developed the current level of cognition. We are fundamentally dependent on a myriad of essential neurochemicals produced by microbes. And the brain's 5-HT system, which plays a key role in emotional activity, does not develop appropriately in the absence of microbes. So the HT system, hydrogen system, which is responsible for, the lack of it is responsible for the depression, very strong relationship. of major importance for societal functioning is a human trait of sociability. And today we are all talking about social cognition. We are social creatures with superior cognitive functioning, which enabled us to become the dominant species on the planet. And today, in fact, we are raping the planet. In rodents raised without any bacteria, one sees altered sociability with clear autistic-like patterns of behavior. So this is another interesting area of work, and autism and the gut is actually another big area of work. Postnatal gut microcolonization occurs in parallel with cognitive development, and there is increasing evidence to support the view that the evolving cognitive activity is critically dependent on the microbiota and its metabolic activity. So this is the paradigm shift which I am talking about. And of course, this is again a cartoon where you have phenotypes of germ-free mice, and which you have the behavior and the cognition and the neurochemistry, and you see that the actions of recognition, memory, sociability, anxiety, locomotion, and self-grooming are all mandated by the neurochemical changes in the brain. And if you do not have these germs, then you will find a problem there. Again, stress and gut microbes. There has been interesting work happening in the area of stress. Again, stress would cause alteration of the 5-HT or the 5-hydroxytryptamine, increase CRF, adrenal cortex, cortisol. We discussed about that. In the liver, increase IDO, and of course the probiotics and the cortisol will act on the gut again, on the gut epithelium. So there appears to be a direct correlation between stress and the gut. So going back to the old cartoon also, that in the germ-free individual, germ-free mice, altered neurotransmitter signaling is there, the reduced anxiety, increased HP axis activity, and decreased BDNF, which will cause the dysbiosis, which is basically memory impairment, reduced neuroplasticity, increased anxiety. And on the other hand, when you have reduced anxiety, that is the healthier state, you have probiosis, you have symbionts, you have increased stress resilience, reduced anxiety and depression-like behavior, and increased neuroplasticity. So there appears to be a clear case that the microbiome can play a role in the modulation, not just of cognition, but also of the emotions. In depression, similarly, we have got interesting studies in the mice again. Increased concentration of pro-inflammatory cytokines seen in major depressive disorders, lack of levels of serum antibodies against the lipopolysaccharide from gram-negative enterobacteria are higher in patients with MDD, and depression alters the gut microbiota. This is evidence-based medicine, of course. This is again a cartoon from 10 Trends in Molecular Medicine, again suggesting that in the healthy CNS you have a diverse microbiota, you have got the integrity maintained in the intestinal barrier, and the pathobions are kept in check, while when you have the dysbiosis, that is the pathobion overgrowth, promoting loss of the intestinal barrier, also called leaky gut, you have gut dysfunction, and stress and disease can have a direct impact upon this. In a mice model of stress due to social disruption, bacteroids are reduced while Clostridia are increased, resulting in a pro-inflammatory change in the profile of cytokines produced by gut microbiota. So from the healthy to the unhealthy microbiota. Germ-free mice show an exaggerated HPA response to stress and the amount of CR relief in response to stress. Introduction of B. infantilis corrects the abnormal response of the HPA to stress in this model, suggesting that the intervention can now start to happen in the human beings also. This is animal data, of course. Human studies show increased bacterial translocation in stress-related psychiatric disorders such as depression. Recent studies have shown that the potential probiotic Lactobacillus formicinus can prevent barrier leakiness, and this underlies its capacity to reverse psychological stress-induced HP axis activation, further confirming the importance of the gut-brain axis in modulating stress response. So this is an important area of work today of how you can modulate stress response purely by acting on the gut by using specific agents. And this is again a cartoon showing a similar thing. Once again, stress altering the barrier function, and this is the role in the pro-inflammatory cytokines IL-1 and IL-6 together with 5-HT, which influence the release of CRF and the ABP from the PVN of the hypothalamus. Probiotic bacteria can alter gut barrier function via the vagus nerve, which may impact on key central NT systems. There has been an interesting study where Tilsch et al. Showed that ingestion of a probiotic cocktail altered information processing of emotional material. Healthy volunteers were given Lactobacillus helvictis and Bifidobacterium long gun in combination of placebo in a double-blind randomized controlled trial parallel group study for 30 days. 24-hour urinary free cortisol output was reduced with probiotic treatment. So this is a very interesting work happening. Then this is a cartoon again to show the role of anxiety. So again, when you have increased anxiety like behavior, low rate of anxiety, which is healthier, you have less of gut inflammation, less of pathogenic bacteria, less of systemic immune response, less of food-borne pathogens, provide treatment, antibiotic treatment. So that is where anxiety and depression are linked to the gut microbiome, which is the focus of discussion today. Once again, depression in the gut, we see that the microbiota composition also has a potential target for treatment with probiotics. The most consistent biological markers associated with major depression relate to a dysregulation of the HPA axis, which is the main stress axis in human beings, and the gut microbiota has been shown to influence this axis. So HPA axis is what we have taught since the MBA days, since the MBBS days, and that is where the gut microbiota is shown to influence in that area. Patients with more severe forms of depression hypersecrete cortisol. Animal models have shown there is an altered microbiota and depression-like behaviors which has led to a search for melancholic microbes in human beings. Jiang et al. Analyzed fecal sample of 46 patients with major depression and 30 healthy controls. Patients acutely depressed had higher level of bacteroids, protobacteria, actinobacteria, whereas levels of homicutes, which were the healthy microbiota, was reduced. So negative correlation was observed between the fecal bacterium and the severe depressive symptoms. So that is why I'm saying that in the past, the somatization and the gut complaints in relation to anxiety and depression now seems to bear some kind of correlation with the animal data which is now coming up. So once again, that is more or less the same thing. Again, in the depression, the gut-free mild depression alters, so it's more of a repetition. The questions that we have for the audience today is that we don't have answers to. Does altered diet in depression contribute to changes found? Does prior antidepressant therapy alter the microbiota? Does the altered microbiota produce metabolic changes capable of influencing brain function, for example, change in short-chain fatty acids? So it may be a secondary effect than a primary effect. And can altering the microbiota produce a change in the mental state of a depressed patient? So I will now shift gears. We'll talk about the anxiety and the dysfunction of the neurotransmitter is well known. The activation of the HPA axis is well known, and the role of CRF is also well known. There is a reduced level of GABA, which is basically an inhibitory neurotransmitter, and serotonin. So the role of GABA. So normally GABA inhibits cellular response to anxiety producing stimulus. People with predisposition to phobic disorders have GABA deficiency. The benzodiazepines which they are using work on the GABA receptors, hence the importance of that. Now in the basal nucleus of the thalamus and in the amygdala, there appears to be a clear correlation between anxiety and the amygdala function. The thalamus, the sensory association cortex, the PFC, and the hippocampus, clearly increasing the size of the amygdala in patients who are anxious and depressed, and a smaller size of the hippocampus. So we are now able to correlate the 5-HT, the GABA, the glutamate, the CRF-HP, and the norepinephrine, and the voltage-gated ion channels with the amygdala-centered circuit correlating with fear of panic and phobia, suggesting that these neurotransmitters hereby listed work on the amygdala and create the fear and panic. So this is the kind of general anxiety symptoms that we associate with panic disorders, which is amygdala mediated. Amygdala is a portion of the brain which becomes larger, in fact. Now, when you look at stress, so what happens is that the biological endophenotype, unprovoked, provoke compensation with emotional trauma, repeated provoked still compensation, and unprovoked irreversible stress sensitization, and you have the breakdown and you have withdrawal here. So from no symptoms to symptoms but resilience, so you have no symptoms but loss of resilience, and then you have a vulnerable phase but pre-symptomatic. So therefore, meaning that whenever, so both at the level of the endophenotype, both the symptom endophenotype, what is called as the phenotype or the external expression, or the biological endophenotype, when we are unable to maintain the homeostasis, that is the time when we get provoked into having an emotional breakdown, stress, anxiety, and depression. And of course, it will go on for further to be provoked, lack of compensation, and you have the full gamut of emotional withdrawal and a full psychiatric syndrome. So this is a sequence of events, how stress can damage and how stress can cause an emotional problem. The ABC model of anxiety, of course, is a cognitive model in which you have the alarm, the beliefs and coping system at symptom domain, and in the processes, and in the brain you have the amygdala, the basal ganglia, and the cortex, thinking brain, at the neural substrate. So the model of anxiety today is from both the symptom domain, and the psychological processes, and the neural substrate. So we should treat anxiety because it can result in emergency, high risk of suicide attempts, and high risk of substance abuse. What does the patient want? Rapid symptom relief, no impairment work, desire to improve quality of life, and a medicine that is easy to tolerate. Factors considered while selecting a treatment option: patient's preference, severity of illness, comorbidity, concomitant mental illnesses, complications like substance abuse, previous treatment, and availability of treatment. All common sense things, but of course documented. Treatment options: you can have pharmacotherapy in terms of serotonin-specific reuptake inhibitors, SNRIs, pregabalin, and benzodiazepines, psychological therapy or psychotherapy, and you can explain the advantages and the disadvantages. SSRIs, when given initially, can have the restlessness and the jitteriness and anxiety symptoms, so can be started, but you would have a delay in the effect for a 2-3 weeks. So we advise that along with the SSRIs, you need to start. You can also start adding a small dose of a benzodiazepine for the at least first 2 or 3 weeks of treatment. So these are limitations of the SNRIs, that they can cause onset. The SNRIs are stuff like, the venlafaxine, venlafaxine, or the duloxetine, or now the vortioxetine. Side effects are nausea and the restless sexual dysfunctions, rise in blood pressure, and therefore like. So among the various benzodiazepines, what do you think are so among the benzodiazepines? The mainstay of treatment in the treatment of anxiety, quick onset of action, used all over the world. The psychiatrist prescription pan India is clonazepam is prescribed 10 times more than clobazam. Clonazepam is prescribed by almost every psychiatrist, but 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 the clobazam by only 45% of psychiatrists. An average psychiatrist prescribes 5 times prescription of clonazepam for every one prescription of the clobazam. In telemedicine also, because of a longer onset of action, because of a longer half life, clonazepam is preferred to drugs like lorazepam or alprazolam. So this is in brief. I will now quit and ask Dr. Mohan to share this just to give you a flavor of what the entire area is. I'll emphasize again on the paradigm shift in the way we are looking at it, and now I'll request Dr. Mohan to start his presentation, which is the main presentation today.
That was a wonderful, prelude to the whole talk, sir. And with your wisdom, you made it so beautiful that even people like me could understand what is happening.
Sir.
And now I wonder whether you're a gastroenterologist or a psychiatrist, because you're talking so much on gut microbiota. Now we'll go out of business. So thank you so much for a wonderful start. And thanks to Mankind and Dr. Prashant and the team for inviting me to deliver this talk. And let me share my screen without wasting much of your time. So the brain and the GI, a concomitant connection, is a topic that was given to me. So which is part B of the whole program. So is there a connect is what we are looking at. And absolutely, because you'll be wondering, what is the cartoon that I put where Abdul Kalam is with Aishwarya Roy? So what is a connect? So you'll be wondering, what is a connect between gut and the brain? Brain is so far away somewhere else. Gut is so far down. So what is a connectivity? And so I gave a caption to this. This is when the Rotary International president was visiting India. They met in Delhi. And, I said, the inner beauty meets the outer beauty. That is the caption that I gave here. So the brain and the gut keep on talking to each other. So all the time. So there is so much, if you take all the enteric neurons of the ENS, the enteric nervous system, and lay them out, the number of neurons that you find in the enteric nervous system outweigh the number of neurons seen in the brain. So we have so much of genetic material in the gut that the genes, the genome of the microbiota put together are heavier than the human genome. So we are more microbiome than even human beings. That is what Dr. Saab was trying to tell us, that there's so much that the microbiota contribute to a healthy state of an individual. So this is the gut-brain talk through different mechanisms. So let us go through some of those. So of course, he was speaking about the limbic system, which is important here. And then you have the enteric nervous system, the ENS. And then there is a lot of talk going on through the enteric nervous system, which could be neural, also it could be hormonal. So both ways, because a lot of hormonal peptides are also secreted from the gut mucosa in response to a lot of stresses that it undergoes. And again, the brain, once there is so much of emotional stress, can definitely influence the gut. Say, for example, I'll give you an example. So, a simple example is that, say, for example, you have to face an examination at 9 o'clock in the morning. You have to write a paper, theory paper, and you're just all tensed up about it. And your mom calls you and say, "Eat your chapatis, rotis now and go." And you say, "No, mom, I'm absolutely feeling full." So usually you eat four rotis. Today you can't finish even one. That is because of the neuromed in you that comes from the hypothalamus, and then the fundic receptacle of the stomach is the receiving area. That now it says, "I cannot take any more food. I'm full." That why? Because it is because of stress. And once you write the paper successfully, come back at 1 o'clock home, and then your mom gives Hyderabadi dum biryani, and along with all the meat, you're able to have a royal meal. Why? Because your mind is relaxed. So the mind definitely influences the gut, the stomach, and the intestines. There's absolutely no doubt about it. So depressed people have a delayed gastric emptying. All those who are stressed out have a irritability of the bowel. So many functional bowel disorders are because of the gut-brain talk. And the so-called, they're called the functional disorders because we don't know what is causing them. There is no organic recognizable factor. That is what it is. So it not only affects the motility, also gets affected apart from the secretory status of the intestine, and absorptive status of the intestine also gets affected in this whole process. So the microbiota are a collection of genome and a collection of microbes. There are not only bacteria, there are also viruses and also fungi. So they are called mycobiota, and apart from the bacteria. So we have 150 times more bacterial genes than even our own human genome. So the bacterial dysbiosis is a cause for disease. That is very clear today. So the bacteria are very less in the stomach because of the high acid levels. So if you see only tricky organisms like the Indian politician Helicobacter pylori, I call him a politician because he knows how to survive even in the worst possible milieu of gastric acid. My teacher, Dr. Madhura Gopalan, used to say, which is the most wonderful organ in the human body. People used to say the brain, the heart, and he used to say, no, it's a stomach. Why? Because it during periods of hunger, it can secrete as much acid that it can go down to a pH of 1, which, if you take it and put it in a beaker and put a nail, it will just dissolve it. As acidic as the battery in the car, the car battery acid, as acidic as that, hydrochloric acid, so much, but still does not digest itself, its own self. It can protect itself. And also, the moment you enter into the duodenum from here to here, the moment you cross this pyloric ring, it becomes alkaline in pH. What a wonderful human body, because we need acid for digestion. But the intestine cannot tolerate this acid because it doesn't have that protection as the gastric mucosal barrier has. So there are a lot of things happening in the stomach. So the stomach has got so much acid, none of the bacteria can survive except for Helicobacter pylori and some of its cousins, and then Streptococcus. And then as you go down, the acidity, becomes completely neutralized. It becomes alkaline. The more alkaline it becomes, the bacteria start increasing. So in the jejunum, it is lesser. As the distal jejunum and ileum, it is much higher. And in the colon, they are the highest. So this is how the bacteria live there. And in small intestine, a bacterial overgrowth, which can happen in diabetic population, in some of those with dysmotility disorders, the bacteria can grow even in the jejunum. They produce a lot of problems. So we pass in an endoscope and put in a catheter and then aspirate the juice from the jejunum and culture and make out what are the type of bacteria, so which are grown. And then once you treat it, then all the dyspepsia disappears, including dyspepsia and diarrhea, chronic diarrhea, dyspepsia. We can always do this. So as our eminent speaker, Nagpalji, was pointing out, the bacteroides, and all these, or more in the jejunum, and again in the colon. So some of these are good bacteria, some of these are bad bacteria. Like for example, Methanobrevibacter smithii is a small bacteria which can produce methane from our food products. So sometimes, like the gas production can be really obnoxious because of different set of bacteria that we get. But what we know is the typical Indian type of frugal diet with more of fruits and vegetables and grains and less of animal meat and fat can be protective to the health of an individual. So this has been well proven over hundreds of studies. So the microbiota, as I told you, can help the host also in providing energy. Almost like 10% of energy is provided by microbiota in our gut. So they lie in the unstirred mucus layer on top. Then stirred mucus, and to some extent good bacteria lie in the unstirred mucus layer also. But the deeper mucus layer is devoid of bacteria, so that the enterocytes are protected. So these can produce, uh, dipeptides. They can produce short chain fatty acids. They can produce, peptidoglycans, and small glycans are small particles. So these can be absorbed, and they provide, like short chain fatty acids, in fact, provide a lot of nutrition to the human host. And the role of microbiota in health is well studied. And the human host provides shelter to them and nutrients to the microbiota, because we keep eating, we keep feeding them. And the microbiome increase the metabolic capacity of the host by aiding in digestion of plant carbohydrates, milk products like glycans, and 10% of calories from the diet. They provide vitamins B12, B2, B12, K, and folic acid. Say, for example, the B12 we may be deficient in, whereas if you check folic acid, all Indians will have more than 5 milligrams of folic acid. Why? That is all synthesized by the gut bacteria. So, because of the high bacterial flora content, that we have more folic acid. So, the microbiota protect the colonization with pathogenic bacteria. This is called colonization resistance. So unfortunately, we didn't have this colonization resistance when the British and the French and the Hispanic, colonized and the Portuguese. So the colonization resistance is given by the good bacteria. We have what is called a gut mucosal barrier. This is made by tight junctions between the epithelial cells, which will not allow any of these bacteria to cross. Whereas some of the products like short chain fatty acids, ATP, PSA, can all cross and enter into the subepithelial mucosa. In the subepithelial mucosa and the submucosa lie a lot of white cells, and the macrophages, the dendritic cells, the Treg cells, the Th17 cells, and there are specialized area called Peyer's patches, which are lymphoid follicles, which have specialized cells. So all these keep interacting with the bacteria all the time. There's a chronic talk that goes on. In fact, you'll be surprised to know that the maturation of the immune system in the gut happens in human beings because of bacteria. They regulate. For this is, I can speak for even 1 hour on this topic, but this is not the forum. So let us just move on. So microbiota stimulation leads to B cell switch to IgA, regulatory T cell induction, T cell differentiation to helper Th17 cells. So thereby they regulate. So they protect. They compete and adhere to the sites of attachment at the brush border of the intestinal epithelial cells, compete for available nutrients, produce antimicrobial products like bacteriocins, which can prevent the colonization of pathobionts or the bad bacteria. So all this will prevent the attachment subsequent entry of pathogenic bacteria into epithelial cells. So this is in health, there is a homeostasis between, and the microbiota are dense and diverse. And so with a lot of metabolic activity. This gets altered if there is dysbiosis. That leads to disease. So this is important. So which can be because of external influences like diet, prebiotics, probiotics, as Sir was pointing out. Pre-probiotics can be beneficial to the host. Antibiotic usage can worsen it. And then illness, lifestyle, especially stress factors. So living environment, all these are external. Internal host properties, say stress has been introduced here also importantly, because stress can affect the whole internal milieu of the human gut. So age, genetic stress, physiological processes, all can alter the microbial, flora of the gut. There's what is called a leaky gut hypothesis. So where the gut epithelial layer becomes disrupted, and because of the tight junctions are gone, so this bacteria and the bacterial products can directly cross. Otherwise, there's a tight junction which produces a barrier. Like only selective things can cross, not everything can cross and stimulate these lymphocytes and mast cells. Here, a lot of bacteria come down, so there is an immune activation, and these immune cells, they produce cytokines, chemokines, which activate the mast cells, and the mast cells, produce their products which can irritate, like histamine and all, will irritate the enteric nervous system. So thereby, there is a dysmotility of the gut that happens. So, and bad bacteria can also go through the portal circuit to the liver and can produce damage there and can enter into systemic circulation. So all these are possible, especially in cirrhotics. They can easily enter into the systemic circulation because there are portosystemic shunts. In healthy livers, our liver has got reticular endothelial cells, macrophages, and dendritic cells, the ito cells, which can prevent this bacteria from transgressing from the liver to the systemic side. And you see here, this is a case of irritable bowel syndrome, IBS, which is a functional disease. If you see here, generally there are the tight junctions. I was talking about the epithelial barrier between the two epithelial cells. There are tight junctions which are held tight by claudin, occludin, E-cadherin, desmoglin, desmocolin, desmoplakin. There are so many of them which hold it tight. So this is under electron microscopy a normal healthy subject. Whereas here you see there are gaps. So these are the leaky gut. This is the concept of leaky gut. So the gaps widen with widening disease, increasing disease. So what happens is there is more pain because more bacterial products can go across, stimulate the mast cells, which degranulate and can stimulate the enteric nervous system, the neurons producing pain. And the pain is measured in the brain as something really painful. So the patient becomes depressed. So there is always a connect between the gut and the brain. So, like one of the important, apart from the malabsorption, diarrhea, IBD, IBS, SIBO, and all that, the non-mucosal disease, the major thing is depression. Apart from others, chronic fatigue syndrome, even fatigue syndrome can happen because of bacterial dysbiosis. Please remember that. So the gut microbiota and brain, there is always a communication, as I told you in the initial slides also, and the cartoons that I showed you. So these, the neurotransmitters are produced. There's a beautiful cartoon which is in the Nature Reviews Neuroscience. So what happens is this, from the brain, the hypothalamus, the CRF is secreted, and then this stimulates the pituitary to release the ACTH. That stimulates the adrenals to produce steroids, the cortisol, and the cortisol can act on the enteric muscles and the immune cells, both ways. So this way that the brain can give its contribution by constant trigger of the brain can produce an increased cortisol and increased stimulation of the enteric muscle cells and also immune system. Also, the bacteria can also play their role in altering the mood and cognition and emotion. And so this is a two-way system that it keeps constantly getting irritated, and the vagus nerve ultimately can not only act on the neuronal connections in the enteric nervous system, also on the immune system. So all this is important to understand. Once I knew that from the experiments, there was mice experiments. I think Nagpalji was very beautifully mentioning. They took 3 sets of mice, which are germ-free mice. In one group, they did not put any bacteria. In one group, the second group, they put good bacteria. In the third group, they put bad bacteria, and they watched their behavior. What they found was that the all the zero bacteria mice were inert and not doing anything. The good bacteria ones showed healthy behavior, whereas the bad bacteria ones showed an aggressive behavior. So once I learned from the mice experiments, it is a bacteria that is responsible even for the emotions. From that day onwards, whenever my wife shouts at me or chases me with something in the hand, I don't care because it is not her mistake. The fault is on the microbiota. So the microbiota can alter the acetylcholine response, noradrenaline, adrenaline, GABA, serotonin. All these are neurotransmitters. So all these responses can be altered by the bacteria, and these also can alter the gut flora because of dysmotility of the gut. So it is a very intricate pathway. So where there is a role for genes to play, and then of course the short chain fatty acids are always good. They are healthy to the body, and then you have the vagus nerve which stimulates, and then you have the cytokines that goes from the the white cells in the subepithelium mucosa or the submucosa of the gut and go through the blood circulation to the brain, and also the tryptophan metabolism, the serotonin that comes, and which are all neurotransmitters. Very important. We'll talk about it soon. Right. So what is how the neurotransmitters affect the GI function? First one is a GABA. So GABA is released from the central nervous system, which relaxes the lower esophageal sphincter. So LES is relaxed and people can get reflux. Then they get GERD. Norepinephrine comes from CNS, spinal cord, sympathetic nerves. It decreases the motility. So there is stasis. So gut becomes paralyzed. Increased contraction of sphincters inhibits secretions. The acetylcholine is a stimulant. It increases motility, relaxes sphincters, stimulates secretion, and serotonin facilitates secretion and peristalsis. So these four are important, and all these may be deranged even by depression and anxiety, apart from the gut microbial dysbiosis. So the serotonin is an important biogenic amine that functions as a neurotransmitter. Its precursor is tryptophan. It's involved in the GI secretion and gut motility and also pain perception, maintenance of mood and cognition. So if you can elevate your serotonin in the brain, you feel comfortable. Like we have a product called green coffee. It's called VGM's green coffee. And we have demonstrated that the brain serotonin goes up if you take green coffee. So which is very helpful. It gives you an upbeat mood. Even when you're depressed and down and lack energy, just taking some green coffee will pep up your mood. So 95% of serotonin is contained in the gut and the mucosa and the nerve terminals of the enteric nervous system. Alterations in serotonin transmission may underlie pathological symptoms. So this is where the selective serotonin reuptake inhibitors are known to modulate the psychiatric disorders and also the GI disorders. Usually the psychiatrists use high dose, we use low dose in functional GI disorders. I'll come to the topic of functional GI disorders soon. Right. So the gut hormones and the neuropeptides are important. There is something called a neuropeptide YY is also there. So this also, there's a lot of things can happen, right? From pain sensation to food intake, energy homeostasis, anxiety, mood, cognition, all are regulated by neuropeptide Y. So very important here. And again, a lot of others, how like we have been speaking about it. So here, the microbial factors, the gut hormones, cytokines, sensory neurons, all can, go to the brain and can change the appetite, energy homeostasis, emotionality, mood. So stress resilience and recovery and learning and memory can also be affected. It can cloud the memory, and sensation of pain also can be aggravated. Like very typical example is irritable bowel syndrome. So my chief, Dr. N. Madana Gopalan at Madras Medical used to, erstwhile days, 40 years ago, used to call it irritable alimentary syndrome and irritable bowel syndrome And he used to say that there are many officers who are irritable, and they should be called IAS officers because they are irritable alimentary system. So, like this is all because of a gut-brain interaction. Because not only the neural side, but also the hormonal side, lot of changes can happen. So the gut can communicate with the brain via hormonal signaling, gut peptides from the enteroendocrine cells. So ETEC can directly act on the brain. Ghrelin, gastrin, orexin, the cholecystokinin, and leptin, neuropeptide Y can all act. So now, this is more and more important today because of obesity and eating habits. Now we want to control. So this is very important. Orexin, ghrelin, leptin, they're all very important. So in regulating the eating behaviors, especially in the obese people, we always tend to regulate this. So this is a big science by itself. So I think those who are interested can go in depth in this area and can understand that germ-free studies suggest that gut microbiota mediates and regulates the release of gut peptides, which can be the cause. So again, the short chain fatty acids are friends to the gut. Our healthy bacteria, the so called symbionts, lead to a production of short chain fatty acids from our own food substances. And these can, produce a sense of satiety, or can also stimulate gut motility, and they can suppress inflammation. They can also prevent cancer. So, the very important, the short chain fatty acids derived from the microbiota, and the microbiota have to be healthy, friendly microbiota. The bad bacteria can produce the reverse. So, digestive disorders are a group of conditions that occur when the digestive system does not function as it should. And it has got two classes. One is organic and functional. What is organic? You can diagnose something. You do an endoscopy, colonoscopy, CT, you can find something. Whereas functional is one where you do all the tests, you don't see anything, you don't find anything. That's a functional GI disorder. So some of the important GI disorders are IBS, gallstones, Crohn's, celiac, SIBO, the small intestinal bacterial overgrowth that I spoke about, GERD, ulcerative colitis. But some of these can have an organic basis. Some of these we don't know. For example, Crohn's and UC, we don't know what causes it, but we know there is an unabated inflammatory response by our own immune cells on the gut mucosa. So we know that gallstones can be because of fat female fertile 40, and it can be because of other reasons, like my chief used to say, single, slim, slender, and 16 can also have gallstones. So this is important. Celiac can have an organic basis because of the gluten in the wheat. So, but whereas IBS, we don't know why it happens. At least in a subset in India, we know it is post-infectious IBS, which produces a bacterial dysbiosis, a leaky gut, which produces a problem. So again, small intestinal bacterial growth, very important in diabetics, long-standing diabetic, especially with autonomic neuropathy, uncontrolled diabetes, the chronic diarrhea, dyspepsia, you should rule out SIBO. Very important. And GERD, I'll speak about it now. So, portion of psychological condition attributable to GI disease. What is it? So, if you take IBS and ulcerative colitis, if you see the black bar is IBS, and the grayish bar is the ulcerative colitis. So, if you see here, so this scores for depression and anxiety are reported both for IBS and UC when compared to healthy controls. So, which means there is a disease where there is an organic problem going on, also has excess psychological depression, anxiety scores, as much as an irritable bowel syndrome where there is no organic cause. So there is so much of anxiety and depression, not necessarily because of organic disease, even in functional disorder. It's one of the major things that we have to remember, and we need to treat the anxiety depression component whenever you're dealing in the treatment of functional bowel disease. If you don't treat the anxiety depression component of these patients with functional GI disorders, you cannot win over the treatment or get the patient's confidence. They'll keep flitting from doctor to doctor in order to get, see, why the patient comes to you is not for, diagnosis of IBD or IBS or something else, GRD. They want symptom relief. And the symptom relief is possible only if you take care of the psychological, the psyche of the individual. That is important. That is why this discussion on a single key which can operate both the brain and the gut. So the impact of depression and anxiety disorders on GI symptoms and the prevalence in general population has been well studied and published in biomedical research. In this population study, there was a strong relationship between a gastrointestinal symptoms, anxiety disorder, and depression. And the prevalence of severe levels of anxiety depression are considerably higher in patients with GI symptoms. So this is important to understand. So irritable bowel syndrome, where the bowel is irritable, that's all, simple. Patients can have bloat, pain, excess gas, diarrhea or constipation, and mucus in the stool. So this is a Rome criteria, Rome 4, which if there is constipation, the Bristol stool, where the pellety stool or hard stool is type 1 and type 2, it's called IBS-C. And if there is a diarrhea type, 5 and 6, like mushy or watery, liquidish, it is diarrhea type. And mixed is sometimes they get type 1, sometimes they get mushy type 6. So this is a mixed type. So the IBS patients. So what is irritable bowel syndrome? It is recurrent abdominal pain on an average at least 1 day a week in the last 3 months, associated with 2 or more of the following. Related to defecation. So either they can get pain or bloat following defecation or preceding defecation, and associated with change in stool frequency. Some days it's one motion, sometimes it's 3 to 4 motions, sometimes zero. So associated with a change in stool form, appearance is it normally, like type 3, type 4 is normal. So like a banana like motion. Here, sometimes it becomes pellety, sometimes it becomes mushy, then it becomes IBS-EM. So associated, so there is abdomen pain, or now the Asia motility group, we have neuro motility Asia group, we have included bloating here because that is by far the commonest. Some people don't even have pain, but they have bloating. So pain or bloating, according to the Indian scenario, at least 1 day a week in the last 3 months, associated with defecation, change with defecation, related to defecation, associated with change in stool frequency or consistency is irritable bowel syndrome. And you do a colonoscopy, you don't find anything. It's not organic disease, it's a functional disease. So now, this is a very, very busy slide. I don't know how many of you can see if you're watching on a mobile, but if somebody comes to you with abdomen pain, bloating with a change in bowel habits, the first thing that I would do is to rule out anything organic. It's important, especially in people above 50 years. I'll show you what are the alarm symptoms with or without alarm symptoms. First thing you have to rule out organic. And if you rule out all organic, then go through the Rome 4 criteria, as I told you, make a inclusive diagnosis of IBS, and then you can classify into the subtypes, as I told you. And then the treatment, I'm not going through the treatment now. So there are extraintestinal manifestations of IBS: see, drowsiness, headache, back pain, nocturia, dysuria, and or urgency, and then menstrual disorders, dyspareunia. All this can happen because in IBS people, there's more spasm of the smooth muscles here. So what are the red flag signs that you have to be worried about in a patient who comes to you in the OPD? You may think it's IBS, but if there is unintentional weight loss, significant weight loss, there is a growth retardation in a child, or significant vomiting or diarrhea, blood in the motion, pain away from umbilicus, and then pain disturbing sleep at night. Patients also waking up to pass motion at night. That is not IBS. Extra intestinal symptoms like fever, rash, joint pain, aphthous ulcers, urinary symptoms, abnormal labs like anemia, elevated sed rate, and then family history of organic disease, peptic ulcer, IBD, cancers. You have to rule out anything organic that's happening there. So treatment of IBS is very simple: healthy diet and drink a lot of water, physical activity, and then you can give what are called the FODMAP diet. You can just Google search; it'll give you fructo oligodisaccharides and monosaccharides and polyols are called FODMAPs. Anything rich with these FODMAPs can trigger more symptoms in IBS patients. So you can just eliminate them and then slowly introduce one after the other. That is regarding diet. And then, like main symptoms in IBS are pain, bloating, diarrhea, or constipation, whichever. If it is pain, you can treat with antispasmodics and tricyclic antidepressants and SSRIs. So I'm going to show you some. So bloating can be treated with rifaximin because I told you that Methanobrevibacter smithii gets killed with rifaximin. So methane production goes down, bloating goes down. And also malabsorption goes down, carbohydrate fat malabsorption doesn't happen, then no more bloating. And it also acts as a prebiotic which can help in the colonization of healthy bacteria. And then the antispasmodics here again help. And then diarrhea, again rifaximin. Then of course loperamide and codeine sulfate not available today in the market, and mebeverine is good here. And elixodolin is not available in India, but a very good drug. And allosetron in the females only, we don't use in males, is not found to be useful and have side effects. So we don't use any more allosetron. So constipation type, we use macrogols like polyethylene glycol, linaclotide, like plicanatide, lubiprostol. Lubiprostol available here. Linaclotide and plicanatide are yet to come into Indian market. So you can use all these and try to give probiotics, peppermint oil, soluble fiber, which can produce more short chain fatty acids, low FODMAP diet, and then modify alcohol, fat, spicy, gas producing foods, and all that can be modified. A healthy lifestyle like doing yoga, meditation to calm down the mind can always help in IBS patients. So you can educate the patient, tell him that it's a diagnosis, even though it's called a functional disease. You can definitely modify a lot of factors and give comfort level to the patients. So you have to talk a lot to the functional patients, otherwise they're not satisfied. The antispasmodic drugs, like alvarine we don't use, but mebeverine we use, hyoscine and peppermint oil are very good. These are all available here in Indian market, which will give relief to the patient. Antibiotics like rifaximin and probiotics, as I spoke. GERD is yet another problem. So it is on the increase. 20% of Indians have GERD, 30% of Americans have GERD. And it has got a genetic background. People in Minnesota County in the United States in 2009 did studies and found they did 5-generation genetic studies in the contained population in that town. And they found that the GERD can be transmitted through genes. If your father or mother or grandfather, grandmother had it, you can have it. So where there is a loosening of the lower esophageal sphincter, and then there is a dysmotility of the esophagus, clearance of the esophagus of acid is disturbed, and there is a duodenogastro-esophageal reflux, and also delayed gastric emptying of the stomach. So all these jointly can happen in GERD. So, and so many factors can produce GERD. I'm not going through all this for want of time. Signs and symptoms are regurgitation, belching, heartburn, bitter taste, gum irritation, sore throat, hoarseness, chest tightness, asthma. 2/3 of asthma patients are GERD. And so this is important to remember. Lump in the throat, difficulty in swallowing, and bending over is impossible because everything will come into the mouth. So in that case, you need to do an endoscopy, find out if there is erosive esophagitis or non-erosive esophagitis, and how are the symptoms. And we do impedance pH-metry and manometry to find out how is the motility of the esophagus and how much of acid is coming up. What is the D-Meester score? It has to be below 14.7. Anything above that is abnormal. So we find out how much of acid is coming up and staying here for how long, during night or day, and then we just give a tailored therapy. So we can make beautiful tailored therapy. We can treat with pharmacotherapeutic drugs, or endoscopic tightening of the LES, or you can go for laparoscopic tightening of the LES. All these are possible today. But what is more important is lifestyle changes. Avoid stress, de-stress oneself by doing yoga, meditation, dhyana, pranayama, whatever. Avoid smoking. And if you're overweight, you have to lose weight. The more the BMI, the higher the reflux. So it's important. So, and you have to ask the patient to be upright for 3 hours after a meal and elevate the head end of the bed by 6 inches and eat a healthy diet. Do not eat anything, too much of foods or alcohol or chocolate or peppermint, and, no alcohol, no smoking, no chocolate, no peppermint, and no banana because it has vanillin. I was telling a youngster Then he looked at me and said, "Doctor, is it worth living at all?" So this again is a problem. So you need not completely ban it like in the army style, but you can reduce the consumption of these. So this is important. So we can use medications like H2 blockers are useless in GERD. We always use PPIs with prokinetics. Then we can de-prescribe the proton pump inhibitors, because de-prescribing PPIs is the order of the day, because there are many studies which show that PPIs in the long run can produce high dose long run PPIs can produce a lot of disorders. So we can always, modify the PPA dosing by adding a prokinetic agent. That's what I do. So this is a very, very busy slide. So if somebody has a chronic or recurrent abdominal symptom, the first thing that I would rule out is red flags. Once I rule out a red flag, then we can go through the Rome criteria for functional bowel disease and IBS. Then we can go ahead and wherever there is red flags and wherever they don't fit in, if you think there is an organic cause, they require a lot of tests, then you can go ahead and treat them. So now the final part of it, use of antidepressants in the treatment of IBS and other functional GI disorders have been well proven. The SSRIs, so the selective serotonin reuptake inhibitors, can be useful in treating IBS along with associated symptoms of depression and anxiety. And this is important. Again, antidepressants for the treatment. Another article which came from Michigan University, antidepressants are effective in treating symptoms associated with functional gastrointestinal disorders. People have used antidepressants for their IBS report significant improvement in abdominal pain, as well as reduction in diarrhea, constipation, bloating, nausea, urgency, which means the functional disorders can respond to small doses of even SSRIs and antidepressants. So results of trials included in systematic review, provide modest evidence that SSRIs modulate esophageal sensation. There is what is called acid-sensitive esophagus. You do an impedance pH metry, 24-hour. You measure how much of acid is coming into esophagus. It may not be high, but the patient has symptoms. Why? It could be because of hypersensation of the esophagus. We call it acid sensitive esophagus. And that can come down just with SSRI. So these patients can have functional chest pain. They come with chest pain. And you evaluate, ask your cardiologist to see nothing is there. You then take up for, GERD study. And finally, you find this is functional. And just with SSRI, the patient's heartburn, physiologic acid exposure, positive symptom association, all this improves. So again, another study which has been published in 2011, Therapeutic Advances in Gastroenterology, shows that administering SSRIs seem to be justifiable beneficial option for those with hypersensitive esophagus. Whether this favorable effect of SSRIs could extend to patients with functional heartburn remains to be seen in future studies. There are future studies which are shown. Again, this is useful. So what are the SSRIs that we have with us? Citalopram, escitalopram, sertraline, fluoxetine, paroxetine, dapaoxetine, vortioxetine, and then the fluoxamine. But mostly we tend to use citalopram, escitalopram, or sertraline for this group of patients, which responds very well. I don't at least use much of fluoxetine in this group of patients. And the types of SNRI, again, this is norepinephrine reuptake inhibitor, selective norepinephrine reuptake inhibitors are duloxetine and venlafaxine, and then desenlafaxine, and this is a molecule which I don't know. So at least these we rarely use, but mostly we use SSRIs. So the benzodiazepines also have a role in managing GI disorders. So benzodiazepines, especially the long-acting ones, may through their decreased gastric secretion or relaxation of smooth muscle tones alleviate GI symptomatology and contribute to patient well-being. So the use of benzodiazepines in GI disorders may facilitate a transition of patients from pharmacotherapy to psychotherapy, which is effective treatment, particularly for functional symptoms, and may produce enduring results. And see here, the benzodiazepine receptors are seen in the brain. So, and like they go through the GABA pathway, or psychological conditions can affect, and they go through the neural pathway, endocrine pathway, and can alter even immune function. So they can increase, stress can increase even pro-inflammatory mediators like IL-1, IL-6, and TNF alpha and interferon gamma, whereas and reduce the anti-inflammatory molecules like IL-10. So they can play a role on the gut enteric nervous system. What are the benzodiazepines that we have? Lorazepam, clonazepam, and diazepam. They can all act against this, stress-induced changes that happens in the enteric nervous system and the gut. So the lorazepam, clonazepam, and diazepam, all these are good. So diazepam we don't use much now. Today we use more of clonazepam and lorazepam. I fondly use a lot of clonazepam and also lorazepam. So in summary, intricate neurological and physiological factors enable the bidirectional communication between the gut and the brain. So it is neural and hormonal. Microbiota can influence the behavior, neurophysiology, and neurochemistry. Antidepressants are likely to remain the mainstay of treatment of functional esophageal disorders and esophageal disorders with a functional component, despite limited evidence from well designed clinical trials for their efficacy. Benzodiazepines may, through their decreased gastric secretion and relaxation of the smooth muscles, tone, reduce the spasm in the GI tract. Because an IBS patient may have a spasmodic pain. If you palpate, you can even palpate a spastic colon. So we used to call it spastic colon syndrome those days, 40 years ago. So the benzodiazepines can alleviate all this GI symptomatology, contribute to patient well-being, because for that reason is the patient, comes to you, not for the treatment of a particular label. Just because you label somebody as something, he doesn't come to you. He wants symptom relief. And for that, you have to really help. So the use of benzodiazepine in GI disorders may facilitate a transition of patients from pharmacotherapy to psychotherapy. Because right from in IBS itself, some people may have lower levels of psychiatric overlay, whereas there can be overt psychiatric patients where then we request the help of psychiatrists. But generally, as a clinician, we can many a times manage many of the functional symptoms of these patients just with the help of SSRIs and benzodiazepines, definitely giving a relief to the patient and his disorder. I bring greetings to you from BGM Hospital with all the team of specialists that we have, that we are able to do some good work in this part of the country. I thank Mankind for giving me this opportunity.
Thank you, sir. Thank you so much. And thank you, Dr. Nagpal, sir. Sir, I know it is, it's already, more than, it's above 7. Can we take a few questions? There are plenty of questions.
Okay.
Okay. Thank you, sir. So, sir, first question, doctor wants to understand. Sir, I'm just throwing up the question. Whomsoever you want to answer. Sir, how long tricyclic antidepressant can be continued? I guess
Indefinitely.
Dr. Nagpal. Yes. Okay. Thank you, sir. I guess Dr. VG Mohan, sir. So, what is the exact symptom that will appear in gut? Because of anxiety. Is there anything specific?
No, it can produce a lot of, it's a, like depression can, halt the motility of the gut, whereas stress can increase the motility of the gut. So from this end to that end, people can have, either irritable bowel in the form of diarrhea, or they can have constipation, and they will have pain. That is one of the major problems. IBS patients, both the groups can have pain, and the pain relief is best achieved by what I spoke, like with SSRIs and, the benzodiazepines.
Okay, Nagpal, sir, so like we are discussing this topic about brain and gut. Is it true for children as well?
Absolutely. Absolutely true.
So, sir, yeah, please, sir. Please.
It is ironic that gastroenterologists are talking more about the brain and the psychiatrists are talking more about the gut. So it's very interesting, because for us it is a paradigm shift to actually go back to the gut, and for you the paradigm shift to actually go back to the brain. So it's a very ironic and very interesting aspect about the clinical practice being changing now.
To add on to Sir's view, we get what is called recurrent abdominal pain in children. We investigate, there is nothing organic. So you have to deal with the child with more psychological counseling and parents and then look at the gut microbiome, try to produce healthy gut microbiota. All this will help.
Sir, the next question is how to treat leaky gut.
Again, as I told you, so first of all, we should reduce the use of antibiotics. Unless otherwise antibiotics are indicated, we should not use. The second thing, we avoid the exposure to pathogenic bacteria. Like our India water source itself is a major problem because there's so much of admixture of sewerage water into our drinking water. Because that is why peculiarly we have water supply and drainage board together. I don't know what these two offices, right from mixing of files in their government office, it also there is so much mixing happens in the road. So what water we get is not a potable water. So after so many levels of filtration, still because ours is an NABH hospital, we keep culturing the water, drinking water every month. Sometimes we get bacteria there, in spite of so many levels of disinfection. So this is highly polluted. So the bad bacteria can go and colonize once you take antibiotics or you have psychological stress. This can contribute to a leaky gut. So we have to take care of both the microbiota, as Sir pointed out, and also the stress. Both are important in preventing a leaky gut, also correcting a leaky gut. You can give pre-probiotics, the so-called symbiotics, and try to correct it. So, right, our nutrition itself, our ancestors were wise. So the best diet is probably the Indian type of diet, not the Western type of diet, which is rich in carbohydrates, rich in fat, rich and dense in calories, especially fructose containing drinks, like Coca-Cola and Pepsi-Cola in the United States are all made from wheat, not from sugarcane as in India. So the not the sucrose, it comes from the sweetening agent comes from wheat, and this can produce bacterial dysbiosis. So it can produce a lot of problems. So, and even fatty liver disease can happen because of this. So I think the diet, exercise, mental health is very important.
Thank you, sir. Sir, I guess this is the last question, sir. Dr. Nagpal, sir. Sir, doctor wants to understand how to keep anxiety at bay at these times.
So there is something, a concept called increasing your resilience or increasing the resilience bank account of an individual. So evidence-based medicine for resilience suggests 7 to 8 hours of sleep every day. Below the age of 45, 75 minutes walk. Above the age of 45, 50, 45 minutes walk every day. Doing or writing a gratitude diary, what is also called as journaling, where you express, in the Hindi expression is shukrana, where you write down 5 things you are grateful to somebody for, some kind of higher power, maybe the fact that you're healthy, you have parents staying with you, your children, etc. Doing some kind of meditative technique. There are several types available today, but I'm not focusing on the kind of meditation, but some kind of meditation technique, preferably having learned from somebody, that is more useful. Then the role of following some kind of passion, some kind of hobby or vocation outside your regular routine. These are factors. And the last point is, which is again very interesting, something we actually dismissed many years ago, was actually gossiping. So gossiping or talking among friends on mundane issues like politics, environment, or some which are of no concern to us doctors, is basically known to open up connections in the brain. And today connectomics, the science of connectomics today in the brain, talks about how gossiping can actually open up the neural circuit. Is very useful for creating a healthy brain. So all these factors are responsible for increasing the resilience, which can help us to improve our capacity to handle stress.
Sir, now today I understood why my wife has got more brain than me, because she does gossiping all the time.
You have a lovely sense of humor, so I can assure you.
Very
It's very
interesting.
enjoyable, sir.
I need you to take a class for us, all the gastroenterologists.
Thank you, sir. Very kind, sir. Thank you.
Thank you, sir. Thank you, Dr. Mohan, sir, and thank you, Dr. Nagpal, sir, for this wonderful session. And definitely, I mean, discussing about the interrelationship between a gut and brain. And so, as I told, I mean, this is the first chapter where we are talking about, I mean, how our gut microbiota, the elementary nervous system is actually connected with our central nervous system. So, and I hope our audience, I mean, who have joined us here, definitely enjoyed this session. And and thank you so much, sir. So, thank you for joining us here, and thank you for entertaining us. Thank you, sir. Thank you.
Thank you.
Thank you, Prashant.
Thank you.
Thank you.
Thank you very much, Prashant.
Bye.